All right, today we're going to talk about and show you how to put on an Intrinsic Plus Splint. An Intrinsic Plus Splint is typically used to provide a low load, long duration stretch to skin grafts and scar tissue on the posterior surface of the hand, especially when the graft or scar tissue crosses the MP joint, where skin requires extra extensibility to stretch over this joint so that we can flex our fingers and make a fist, so that we're able to pick things up, carry things with our hands. The splint positions the wrist in extension, the MP joints in flexion, and then the PIP and DIP joints in extension, so it kind of creates this position. The thumb is abducted off of the palm of the hand, kind of underneath the splint. When donning the splint, a barrier of 1 to 2 fluffs should be placed on this hand and forearm portion or forearm portion of the splint, kind of depending on where the patient's burns are. And this assists with wicking away excess moisture from the skin that might be caused by sweat, drainage from the contact with the thermoplastic material. Burn pads or other bulky dressings shouldn't be used, as they can change the fit of the splint by blocking some of the custom contours on the hand surface, at the wrist, at the thumb, and at the forearm. And additional fluffs can be placed on top of the hand to protect fragile joints that might be exposed. So the splint should be lined up. Well, I'll put my fluffs on first. The splint should be placed by lining up the thumb web space of the splint with the web space of the patient's fingers. So we kind of slide that in. And we want to make sure that we've got good contact between those two surfaces. And then you might have to gently kind of press down on the posterior surface of the wrist to kind of get it in an extended position into the splint. So the 4-inch double roll of ACE wrap should be used for applying the splint. We're going to orient the ACE wrap so that the Velcro is on the under surface of the wrist. We don't want the Velcro in contact with the patient's skin, just to prevent any skin breakdown or irritation. And so we're going to orient the ACE wrap so that we're going to unroll the wrap towards the pinky side here. So once we apply the ACE wrap to the bottom, my other hand's going to hold it in place as I unroll the ACE wrap towards the pinky side across the posterior surface of the top of the hand, and then coming through the web space here, securing the thumb web space with the ACE wrap, and then I'm going to kind of roll back across the bottom of the splint, coming off the pinky side again, making an X over the back of the hand, and then coming down and meeting my Velcro on the bottom. And then I repeat that motion again, so I'm going to roll out towards the pinky side, across kind of the back of the hand. We're going to go a little bit higher, slightly overlap that first wrapping, come out the pinky side, come back down, and now here we'll go, we'll go around the thumb, and then kind of come back down. And then what you're going to do is just finish the wrap down the forearm with a figure 8 until we kind of use up the rest of the material here. And we can overlap a little bit, that's okay. Just making sure that we're not ending with Velcro on the patient's skin. If a patient has long fingers or a larger hand, you might have to do one more additional X wrap at the top here. All right. So, skin should be checked regularly. If the patient has dressings in place, the skin should be closely assessed at every dressing change. And then at least once a shift, the fit of the splint should be checked. So that requires you to remove the ACE wrap, ensure that the thumb web space is still in contact with the thumb portion of the splint, ensure that the splint hasn't migrated or that their arm hasn't rotated inside the splint. If the patient isn't in any dressings and you can visibly see their skin, then the skin, the skin and the fit of the splint should be assessed every shift. When assessing the skin, check the whole hand, wrist, and forearm portion, and pay close attention to any bony prominences. So those include kind of the bottom of our wrist, top of our forearm. There's a couple bony points in the bottom of our palm, across that upper contour of our hand, any of those bony areas, on the sides of our hands, sides of our fingers, anything that might come in contact with that harder material, and then the tops of the fingers. Special considerations and when to collaborate with OT about the splint wear schedule. Adjustments, fit, modifications include if a patient has new IVs or lines that might be where the splint is located, or any monitoring devices that they might need to wear that would be on that extremity. If a patient is in wrist restraints or is very agitated, collaborate with OT about the wear schedule. If the splint is necessary, and kind of how to manage those two things. If there's any excessive drainage from the wound or excessive moisture from sweating, if the patient reports or if you notice any signs of pain from a patient that can't report pain related to the splint, if there's any increased edema or a significant decrease in edema that could impact the fit of the splint, if you notice any new wounds, skin openings, redness in areas that appear to be caused or worsened by the splint. If a patient has multiple splints that we're asking you to put on, OT can collaborate with you on how to do that easiest, how to balance those between day and night, or what splint should overlap with which splint. And if the splint is impacting the patient's ability to participate in functional tasks or functional mobility during the day or night, we can collaborate on wearing schedules and things like that.